Okay, gang, this is our last PowerPoint recording for Unit 3. We will be done with these completely. You can go back and look at whatever it is you need to look at to prepare for the final exam. There is already a reading list of the areas that will be included on the final exam because it's comprehensive. So if you really just utilize the study guides that you have for unit 1, 2, and 3, that will prepare you for the final exam. I'm excited because the spinal cord injury recording is still exporting. I actually, I just say it's just by the grace of God. This afternoon I went back to the laptop and I hit it, and sure enough, the recording is on there. But it says until it finish uploading or exporting or whatever, I cannot send it to YouTube or upload it and share it as a link. So I do know it's there, and you will end up having a second spinal cord injury URL link, and that would actually be the one where I actually recorded on yesterday. So that has really lifted my spirits because I was so depressed about that yesterday. And I want to talk about this last chapter, which is on stroke. And if you look at your syllabus, the first thing that they had up there was about transient ischemic attack, in which we really do not have anything in the PowerPoint about TIAs. But TIAs, I'm just going to give a brief description here, and you pretty much can go back and follow just about what I'm saying in this particular slide about TIA, transient ischemic attacks, and that is the first thing listed under cerebral vascular disease. And so transient ischemic attack, however, is another risk factor that is associated with stroke, and I will follow up with strokes, particularly the ischemic and hemorrhagic strokes. And I'm not sure what you went over in 2200 on these topics. However, a TIA is a transient episode of neurologic dysfunction caused by focal, brain, spinal cord, or retinal ischemia, but without acute infarction of the brain. Clinical symptoms typically last less than 1 hour. In the past, TIAs were operationally defined as focal cerebral ischemic events with symptoms lasting less than 24 hours. It is important to teach the patient to seek treatment for any stroke symptoms, since there is no way to predict if a TIA will resolve or if it is in fact the development of a stroke. 1/3 of individuals who experience a TIA do not experience another event. There is also 1/3 that have additional TIAs, and then another 1/3 that actually progresses to a stroke. TIAs may be due to microemboli that temporarily block blood flow. TIAs are a warning sign of progressive cerebral vascular disease. The signs and symptoms of a TIA depend on the blood vessel that is involved and the area of the brain that is actually ischemic. Now, if the carotid system is involved, patients may have a temporary loss of vision in one eye, and I'm not going to even try to pronounce what that is. If you look in your book, is Amaurois Fulgax. Amaurois Fulgax. That is what we call temporary loss of vision in one eye. You have transient hemiparesis, numbness or loss of sensation, or a sudden inability to speak. And I have experienced that with the TIA patient. They'll stir off into one side, almost like they having a focal seizure. They do have difficulty speaking. They can lose sensation in a limb as well. Signs of TIA involving the vertebral basilar system include tinnitus, vertigo, darkened or blurred vision, diplopia, ptosis, dysarthria, dysphagia, ataxia, and unilateral or bilateral numbness or weakness. Now, a TIA should be treated as a medical emergency as it is usually a precursor to an ischemic stroke. We need to teach people who are at risk for TIAs to seek medical attention immediately with any stroke-like symptoms and to identify the time of the onset of those symptoms. So again, TIA is the transient ischemic attack, and it is another risk factor that is associated with stroke. So we'll move to the next slide, and we will start on stroke. And now stroke is ischemic to part of the brain, ischemia, to part of the brain. It can be hemorrhage into the brain that results in death of the brain cells. Stroke is also known as a brain attack or a cerebral vascular accident, and I think that's what we more common, CVA, cerebral vascular accident. The brain requires a continuous supply of blood to provide the oxygen and glucose that the neurons need to function, and a stroke occurs when there is an interruption either from that ischemia to part of the brain or hemorrhage into the brain in the blood supply that results in death of the brain cells. So again, there is an interruption in the blood supply to the brain from ischemia or due to some type of hemorrhage that results in death of the brain cells. Now the term, again, brain attack, that really communicates the urgency of recognizing the warning signs of a stroke and treating it as a medical emergency, and that treatment is just as detrimental as a patient having an MI, and that emergency medical attention is similar to what we would do with a patient who was having a heart attack. Now, the severity and loss of function, it kinds of vary according to location and extent of brain damage. They can have physical, cognitive, and emotional impact on the patient as well as the family. In a stroke, those functions that I just mentioned, like movement, sensation, thinking, talking, emotions, they were controlled by the affected area of the brain that has been lost or impaired when you encounter a person that's experiencing a stroke. And again, it depends on the location that it has occurred in and the extent of the damage when determining which one of those things are going to be missing. Will they have sensation? Will they be able to think and talk? Will they have control of their emotions? Because if you notice, some CVA patients have crying spells just out of nowhere, and it depends on the part of the brain that's been affected. Common long-term disabilities include hemiparesis, which is partial paralysis on one side, the inability to walk, complete or partial dependence for activities of daily living. They become aphasic, and they can become depressed. They also, in addition to the physical, cognitive, and emotional impact of the stroke on the stroke survivor, the stroke also affects, again, the lives of the caregiver and family of the actual stroke victim. Now here, they're talking about again some of the risk factors, and these are the non-modifiable risk factors, and that is age. 2/3 of the individuals are over the age of 65. And gender, more women die from stroke because they tend to live longer and thus have more opportunity to suffer a stroke. A higher incidence, meaning twice as high, and death rates from stroke among African Americans in comparison to other ethnic groups may be related in part to having higher incidence of hypertension, obesity, and diabetes. As far as hereditary, family, and history, genetic risk factors are important in the development of all vascular diseases, including stroke. A person with a family history of stroke has an increased risk of having a stroke, and genes encoded product involved in lipid metabolism, thrombosis, and inflammation are believed to be potential genetic factors for stroke. And individuals who have at least 2 first-degree relatives with a history of subarachnoid hemorrhage or aneurysm should be screened to rule out abnormalities in their cerebral vasculature. Now, I do have some more demographic information that I don't really have a slide on, and I'm just going to mention that before I start this particular slide. It says that stroke is the 5th most common cause of death in the United States. There is an estimated 7 million people over the age of 20 in the U.S. that has had a stroke. With an aging population, it further increases the incidence of stroke. Stroke can occur at any age. About 34% of strokes occur in people younger than 65, and more than 137,000 deaths occur annually that are related to stroke, and that we need to be mindful of this lifelong impact when we are caring for patients who are stroke survivors. And again, with the risk factors, before we go over again, as I said, I had a couple slides before I got to these risk factors. And let me go back and see, okay, the non-modifiable. I think I did mention on the non-modifiable, but before I go on to the modifiable, another thing is that the most effective way to decrease the burden of stroke is through prevention and teaching, and risk factors can be divided again into those 2 groups, non-modifiable and modifiable risks. And stroke risk increases with multiple risk factors. And again, the primary prevention of stroke and the reduction of these risk factors can dramatically reduce the morbidity and mortality that we see in stroke. So, moving on, I had already talked about the non-modifiable risk factors, and now we are on the modifiable risk factors, and I may have to cut this PowerPoint into 2 points, because what I did realize is that if I do it in 30-minute increments, that it uploads faster and I can get the URL, because when I did that PowerPoint that was over an hour on the first one that I used as my test, I think that was on oncological emergencies, that one that was over an hour, it took all day for that to upload. But I did see, utilizing it a little this morning, that it worked better if I didn't go too much over 30 minutes and then upload that and then finish it out. So now with the modifiable risk factors, 90% of strokes are a result of modifiable risk factors. Hypertension is the highest, most important modifiable risk factor. but it is still often undetected and inadequately treated. New recommendations by the American Heart Association include home blood pressure monitoring with a goal of a systolic blood pressure of less than 140 millimeters of mercury. Next is heart disease. Heart disease, myocardial infarction, cardiomyopathy, cardiac valve abnormalities, and cardiac congenital defects is a risk factor for stroke. Atrial fibrillation is responsible for about 25% of all strokes. The incidence of atrial fibrillation increases with age. Oral anticoagulants that we've talked about, warfarin, Pradaxa, they are and adherence, to these medications play an important role in the prevention of stroke. The risk for stroke in people with diabetes mellitus is 5 times higher than in general population. When we go down to smoking, smoking nearly doubles the risk of ischemic stroke, and smokers are 4 times as likely to have a hemorrhagic stroke than non-smokers. Women who drink more than 1 alcoholic drink per day and men who drink more than 2 alcoholic drinks per day are at higher risk for hypertension, which also increases their chance of having a stroke. Illicit drug use, especially cocaine use, has been associated with stroke risk. A waist circumference to hip circumference ratio 2 or above the mid value for the population increases the risk of ischemic stroke 3-fold. In addition, obesity is also associated with hypertension, high blood glucose, and elevated blood lipid levels, which all increase the risk of stroke. Benefits of physical activity can occur with even light to moderate regular activity. The American Stroke Association recommends 40 minutes of exercise 3 to 4 times per week in order to reduce the risk of stroke. A diet that is high in fat and low in fruit and vegetables may increase stroke risk. Women who experience migraines with an aura are at an increased risk for stroke. American Heart Association recommends smoking cessation and alternatives to estrogen oral contraceptives for women in order to reduce the incidence for stroke. And finally, there are other conditions that may increase the risk for stroke, which includes inflammatory conditions such as rheumatoid arthritis, sickle cell disease, lack of exercise, and again, obesity. So, question before I start with transient ischemic attack. As one of your clinical assignments, you are assisting a RN with health screening at a health fair. Which individual is at greatest risk for experiencing a stroke? A 46-year-old white female with hypertension and oral contraceptive use for 10 years. B, a 58-year-old white male salesman who has a total cholesterol level of 285 milligrams per deciliter. C, a 42-year-old African-American female with diabetes mellitus who has smoked for 30 years. Or D, a 62-year-old African-American male with hypertension who is 35 pounds overweight. Now answer that question, and I will be looking for a response to that question on our discussion forum board. And again, I was going to refer you to the pages to look for, but no, I'm going to let you do a little searching for that, and we pretty much have already answered the question for real in our previous slides that we have talked about. So the next is, well, in your book, there is a illustration of the cerebral arteries and the circle of Willis, and it'll go back and you can go over that anatomy again to give you an idea when we start talking about these different strokes, what portion of the brain that's occurring in. And when we talked about increase in the intracranial pressure and all those pictures I put up there for you for neurology to show the different areas that cover what functioning that occurs, it can pretty much tell you the same thing when you have a blockage or in one of these vessels or a stroke, which functioning that your patient is going to lose. So that transient ischemic attack, I had actually kind of talked about that a little earlier on the first slide, but I would do a reinforcement of that, although I thought initially that I really did not have a slide about that, but this will be, again, a reinforcement. With TIA, it's important to teach the patient to seek treatment for any stroke symptoms, as there is no way to predict if a TIA will resolve or if it is in fact the development of a stroke. TIAs may be due to microemboli that temporarily block the blood flow. TIAs are a warning sign of progressive cerebral vascular disease. The signs and symptoms of a TIA depend on the blood vessel that is involved and the area of the brain that is ischemic. A TIA should be treated as a medical emergency, as it usually is a precursor to ischemic stroke. And last but not least, we need to teach people who are at risk for TIAs to seek medical attention immediately with any stroke-like symptoms and to identify the time of onset of symptoms. Again, a reinforcement from the first slide. And again, so is this. You can see actually what I was saying, that with the TIA, it's important to teach the patient to seek treatment for any stroke symptoms, because we don't know if that TIA will resolve or in fact if it is the development of a stroke. And it says here, as I had already said in the first slide, 1/3 of individuals who experience a TIA will not experience another event. Then we have 1/3 will have additional TIAs, and 1/3 will progress to an actual stroke. TIAs may be due to microemboli that temporarily block the blood flow. We know that TIAs are warning signs of progressive cerebral vascular disease. The signs and symptoms of TIA depend on the blood vessel that is involved and the area of the brain that is ischemic. And last but not least, TIA should be treated as medical emergency. So it is imperative that we teach the people who are at risk for the development of a TIA to seek medical attention immediately with any stroke-like symptom and to identify the time of symptom onset. So, with strokes are classified based on underlying pathophysiologic findings. We have an ischemic stroke. An ischemic stroke can be thrombotic or embolic. And then we have the hemorrhagic stroke, which will be intracerebral or subarachnoid. Sorry, y'all. Now, this is showing pictures of those major types of stroke. And as you can see in that first illustration, that is the thrombotic stroke, where you see that the process of clot formation, which is the thrombus itself, it results in a narrowing of the lumen, which blocks the passage of the blood through the artery. In illustration B, we can see an embolus is a blood clot or other debris circulating in the blood, and when it reaches an artery in the brain that is too narrow to pass through, it lodges there and blocks the blood flow. And then in illustration C, we see the hemorrhagic stroke, where we have a burst blood vessel that allows blood to seep into and damage brain tissue until clotting actually shuts off the actual leak. So in the ischemic stroke, it results from inadequate blood flow to the brain from partial or complete occlusion of an artery. And again, ischemic stroke, as I just previously said, can be thrombotic or embolic. Now, the thrombotic stroke. The lumen of the blood vessel becomes narrowed, and if it becomes occluded, infarction occurs. Thrombosis develops readily where atherosclerotic plaques have already narrowed blood vessels, and thrombotic strokes are more common in older individuals, especially those with high cholesterol, atherosclerosis, or diabetes. A majority of thrombotic strokes are associated with hypertension or diabetes, or both of which accelerates atherosclerosis development. So as you can see, the thrombotic stroke is the most common cause of stroke in 60% of the population. And again, it is often associated with those persons who have hypertension or diabetes, or a combination of both. Now, the extent of the stroke again depends on how rapid the onset is, the size of the damaged area, and the presence of collateral circulation. Most patients that experience ischemic stroke, they do not have a decreased level of consciousness in the first 24 hours unless it is due to a brainstem stroke or other conditions like a seizure, increased intracranial pressure, or a hemorrhage. Now, manifestations of ischemic stroke may progress in the first 72 hours as infarction and cerebral edema increases. So, again, the thrombotic stroke, the extent of that stroke depends on how rapid the onset, the size of the damaged area, and the presence of collateral circulation. Now, with the embolic stroke that falls under ischemic, again, you got two types of ischemic stroke, thrombotic and embolic. So now with the embolic ischemic stroke, that stroke occurs when an embolus lodges in and occludes a cerebral artery, resulting in infarction and edema of the area supplied by the involved vessel. With embolic stroke, the patient who experiences an embolic stroke commonly has severe clinical manifestations that occur suddenly. Embolic strokes can affect any age group. Rheumatic heart disease is a cause of embolic stroke in young to middle-aged adults. An embolus arising from an atherosclerotic plaque is more common in older adults. Warning signs are less common with embolic than with thrombotic stroke. The embolic stroke often occurs rapidly, giving little time to accommodate to an obstructed blood vessel with the development of collateral circulation. The patient usually remains conscious, although he or she may have a headache. The effects of emboli are initially characterized by severe neurologic deficits, which can be temporary if the clot breaks up and allows blood to flow. Smaller emboli then continue to obstruct smaller vessels, which in turn involve smaller portions of the brain with fewer deficits. The prognosis is related to the amount of brain tissue deprived of its blood supply, and recurrence of embolic stroke is common unless the underlying cause is aggressively treated. Now, hemorrhagic stroke, it results from bleeding into the brain tissue itself. Again, it is either intracerebral or intraparenchymal hemorrhage. And then we have the subarachnoid space or ventricles, where you have subarachnoid or intraventricular hemorrhage. Now, with the hemorrhagic stroke, the vessel usually ruptures in the basal ganglia. 50% of deaths occur within the first 48 hours in these people. And again, as you can see listed here, there's a sudden onset of symptoms, progression over minutes to hours because of ongoing bleeding, and the prognosis is poor with a 30-day mortality rate in 40 to 80% of these people. Some other causes, and looking at what that looked like, that's really bleeding into the brain. And that really, really looks bad. It really does. So you can find that illustration in your book, the same way it is on this slide. I did have my book open to reference you to a page, but you can find this. Well, I can, find the page right quick. I've been trying to reference different pages if it's something that you want to directly go and look at. So this particular illustration is found on page 1349 in your text. It is figure 57-3. And it says that is a massive hypertensive hemorrhage rupturing into a lateral ventricle of the brain is what that is a picture or illustration of. Now, the hemorrhagic stroke, continuing with that, there are other causes that include vascular malformations, coagulation disorders, anticoagulant and thrombolytic drugs, trauma, brain tumors, and ruptured aneurysms can all be causes of a hemorrhagic stroke. A blood clot within the closed skull can result in a mass that causes pressure on brain tissue and actually displaces that brain tissue, and it will cause a decrease in cerebral blood flow, which will lead to ischemia and or infarction of that tissue. So again, the intracerebral hemorrhage, hypertension is the most common cause. Hemorrhage occurs during activity. It has a sudden onset with progression over minutes to hours, and extent of those symptoms vary and depends on the amount, location, and duration of the bleeding. Manifestations, signs, and symptoms that we'll see with the intracerebral hemorrhage. We see neurological deficits. Approximately half of intracerebral hemorrhages occur in the putamen and internal capsule, in the central white matter, the thalamus, cerebellum hemispheres, hemispheres. I'm sorry, I'm getting tongue-tied. And in the pons is the area that these occur in. Initially, these patients, again, will experience a severe headache. They'll have nausea and vomiting. And when they experience hemorrhage in the pons, that is the most serious, because our basic life functions, like our respiratory center is located there, that becomes rapidly affected when we have a hemorrhage in the pons. And as we know, hypertension plays a major role, and as they experience bleeding into the brain, it causes a decrease in the level of consciousness. Now, continuing with a hemorrhagic stroke, we have subarachnoid hemorrhage, abbreviated SAH, and that is intracranial bleeding into the cerebrospinal fluid filled space between the arachnoid and pia mater. Is commonly caused by rupture of cerebral aneurysm, trauma, and or drug abuse. Now, cerebral aneurysm is up next, and I'm not sure how many slides that'll take up, but I do know that I am about 36 minutes into this portion of the presentation, and I am going to stop here and allow this to upload and go back to trying to pick up on this. I was hoping I could do this in two. I don't know, maybe I'll go a little farther, because this, like I say, this PowerPoint presentation got like 123 slides, and right now I ain't even a fourth of the way through here talking about stroke, because they tell you about the stroke, then they want to go back over in the book and tell you about the management instead of putting all of that together, which I should have flipped through these slides, but because of the way the slide presentation is, I didn't want to take you through going back and forth the way that I would have to do in order to put this together. So before I start on cerebral aneurysm, I am going to end this, and I will pick up cerebral aneurysm again. It's still under hemorrhagic stroke, and I am going to stop here and let this particular one upload and pick up again on another recording.